Buenas tardes a todos. Esta tarde tenemos el honor de tener en este congreso al doctor Antonello Bonci. Es actualmente presidente y fundador de GIA Healthcare y fundador y director científico de Brain and Care. Antes de mudarse allí a Miami, se desempeñó durante casi una década en el Instituto Nacional de Salud como director científico del Instituto Nacional sobre Abuso de Drogas. Estuvo en la UCSF entre 1999 y el 2010, y cuando dejó eso era profesor residente en el Departamento de Neurología de la Universidad de California, San Francisco, el departamento de neurología mejor calificado del mundo. El Dr. Bonci es conocido mundialmente por sus estudios pioneros sobre los efectos a largo plazo del estrés y exposición a drogas en el cerebro. El laboratorio de Dr. Bonci fue el primero en demostrar que las drogas de abuso, como la cocaína, modifican la fuerza de las conexiones entre las neuronas y producen plasticidad cerebral. Este estudio, publicado en Nature, arroja una nueva luz sobre el fenómeno de la adicción a las drogas como un proceso en el que el aprendizaje desadaptativo juega un papel central. Mucho gusto, muchas gracias. Adelante, cuando quieras.
Grazie, Paolina. It's a pleasure. Thank you. Sorry for the confusion yesterday, but we are here now. We do our best.
Okay.
So I'm gonna share my screen.
Okay.
And I also typed in the chat my email address, because if anybody has questions later that they don't get to ask, they can always email me, and I will answer questions, send them articles, whatever I can do. Okay.
Okay. Thank you.
So let me upload my talk. About to share screen. Yes. This is my presentation. Now I wanna wait. Now I wanna open another window. Okay, let me see. Can you see this window?
Of course, perfectly.
Perfect. Okay, it's the entire screen, right? I don't see you anymore. Okay, perfect. So I'm gonna give a very simple summary on transcranial magnetic stimulation. And this is a technology that has been around for basically 40 years, 40, and that has recently exploded in terms of popularity and applications of TMS. So we're going to go through a lot of science and clinical relevance for transcranial magnetic stimulation. This is always the disclosure. I don't own, or I'm not affiliated with TMS companies. I don't have intellectual properties on TMS. And as you were saying before, I'm a co-owner of my clinics, GIA, the many GIAs, Vita Recovery and Brain and Care in Europe. And it's a scientific presentation, so you know that. We're going to talk initially about the history and practical features of TMS, our research, and evidence related on what TMS does to addictions, and some other clinical applications on TMS. I can also share, Paolina, this entire presentation via a PDF with you if you want to share it with people.
Of course, that's a great idea.
Okay.
Thank you.
Okay. So, I mean, I can go fast here. We all know that the COVID-19 epidemic has created a lot of problems. People have more anxiety, more depression, more addictions, more burnout. It has changed the world in a very strong way. And TMS can actually be very useful, not as a substitution of therapies like what Maria does or what doctors do with diagnosis, but it's an addition, but it's a very, very powerful addition to existing therapies, which is what we usually do with transcranial magnetic stimulation. And we're going to talk about the frontal cortex. The frontal cortex is this part of our brain, and is actually the most important brain region in our head, because every decision we make, it depends on normal activity of the frontal cortex. And one concept that I'm going to touch upon is that our brain, at the end of the day, is very similar to our heart, is controlled by electrical activity. And there are certain brain frequencies that change also in the frontal cortex when things go wrong. Addictions, depression, and TMS tends to rebalance those kind of abnormal brain frequencies and relieve people from their symptoms. But this is an example of what the frontal cortex does. We make actually more than 30,000 decisions every day. So you can imagine how many things can go wrong in terms of good decisions when our frontal cortex doesn't work anymore. Very, very important, and the most important brain region in our brain at the end. This is what I was saying before. Many of our patients actually take medications, or we manage their medications, and we come up with diagnosis. The majority of our patients do cognitive behavioral therapies of many kinds or some form of therapy, like with Maria Elena, and those patients use also in synergy transcranial magnetic stimulation. So it really brings together medicine, psychology, and technology. And when we join forces, then patients see extraordinary results and improvements. Never TMS in isolation, except for some exceptions, very rarely. But usually TMS is administered in combination with many other therapies and medication management and so on. The whole idea around TMS is very simple. Our brain, at the end, are electrochemical batteries. Our brain cells change the frequency of activity, and they are controlled by chemicals, by dopamine, serotonin, GABA, glutamate, and so on and so forth. And the idea, in reality, of electrical stimulation is not a recent idea. Believe it or not, but in Greece, 2,500 years ago, Hippocrates thought of using electrical stimulation by using the small electric fish that you find in the Mediterranean to actually help people with migraine pain. And he was placing this electric fish in the frontal cortex of patients to help them with the pain produced by headaches. So you see how early the idea of electricity and our brain being an electric organ has been created 2,500 years ago. And then in 1700, the science of electricity started in Italy with Luigi Galvani, and the basic principles of TMS were discovered 200 years ago, when in Denmark, in Copenhagen, Ørsted discovered that electricity and magnetism, in fact, the technology is called transcranial magnetic stimulation, were always joined together. There is no magnetism without electricity, and vice versa. And then in 1985, Anthony Barker, a friend and a wonderful physicist, not a doctor, he created the first modern TMS machine, invented for depression. And TMS was actually invented in the mid-80s to help all the patients that were suffering from depression that did not improve with medications. And that is actually the majority of people. About 60 to 65% of people do not improve significantly when they take the usual medications for depression. So we already knew 40 years ago, 1985, that we needed more than just the usual medications. And in 1985, first article on Lancet by Tony Barker and collaborators, transcranial magnetic stimulation was officially brought to the clinic. And I told you already about the Faraday's law. It says that whenever we have a magnetic field, we also create an electric field, which is the stimulation that goes to our brain. And we get, through the electromagnetic stimulation, excitation of our brain cells. And we have many different protocols nowadays for depression, for addiction, for anxiety, OCD, attention deficit, Alzheimer's, insomnia, Parkinson's disease, long COVID symptoms, traumatic brain injury, and that all depends on the brain location and the intensity. But these stimulation protocols are usually between 5 minutes and 20 minutes. So they're not taking the patient a lot of time, and they're very effective. There are many types of TMS machines now. We have these stimulators, like the one that is called butterfly or figure eight, but they're like small and non-invasive, of course, and usually very well tolerated by all patients. In fact, TMS, there are studies showing that it can benefit young adolescents. Children have been studied for autism down to the age of 11 or 10. Older people with Alzheimer's, pregnant women can do TMS in most cases. So it's a very, very safe and well-known technology. And TMS can do two different things to our brain. For example, people with depression have a decrease of activity in the frontal cortex, while, for example, people with anxiety or OCD have an increased brain activity in another brain region called supplementary motor area, for example. And with TMS, we can either speed up a brain region that goes too slow electrically, or slow down a brain region that goes way too fast, like anxiety, OCD symptoms, insomnia, and so on. So TMS can do both things: slow down brain activity when it's excessive, or speed up brain activity when it's too slow. And TMS has a series of neurobiological effects. We have done a lot of studies on that regard. And the summary of these effects, as for the main effects of TMS, is summarized in this slide. We have a chemical effect of TMS, meaning TMS releases a lot of good chemicals: dopamine, serotonin, GABA, glutamate, and so on. TMS has a vascular effect. It increases brain blood flow and oxygenation. TMS produces brain plasticity, meaning creating new brain connections. And also TMS has an anti-inflammatory effect. There are certain pro-inflammation molecules that are actually reduced by TMS. So many different effects and beneficial effects of TMS. And we did a lot of studies before we developed our TMS protocols for addiction. And we started from cocaine. And cocaine addiction is still the second strongest addiction in the world. So there is a lot of need to create new treatments for cocaine addiction. And also, you may be surprised, but in the United States, there are certain parts of the United States where up to 30% of women during pregnancy use either alcohol or other drugs of abuse, which is terrible. And as I mentioned before, TMS can be administered also during pregnancy. And I mentioned before the frontal cortex in addictions, but what I didn't say is that in most types of addictions, like in depression, the frontal cortex activity is reduced. And if you think about it, it's very clever of addictions to slow down frontal cortex activity, because my decision making is done in my frontal cortex. And when I am addicted to alcohol, cocaine, gambling, anything, my decisions are changed. They all go toward my addiction. I want to get that thing. It's okay if I drink a bottle of wine or two. It's okay if I gamble my entire salary in a couple of days. My decisions have been changed by my addiction. And studies have shown by Nora Volkov, by many others, that my frontal cortex in addiction slows down. It's like a heart that beats very slowly. And so we created an animal model very similar to people of cocaine addiction, with the idea in this animal model to speed up brain activity back to normal, to see whether that would change their addiction of rats to cocaine. So we trained rats to self-administer cocaine for a couple of months, 2 months, and then at the end of the training, we had 4 sessions where rats were receiving a food shock, which is a negative consequence. Like if you want to keep on getting cocaine, now that you had cocaine for a couple of months, you now are going to be punished in a sense, and you will get also food shock, which is not pleasant. And what happened was that 70% of these rats would stop, as you can see in the pink square, they would stop lever pressing for cocaine, but 30% of them would keep on lever pressing. These were very addicted to cocaine, and they didn't care about being food shocked. They just wanted cocaine so badly. And when you go and measure brain activity down here in the resistant, shock-resistant rats, basically the cocaine-addicted rats, as you can see here, there is a major reduction of brain activity in these rats compared to the naive rats that have never seen cocaine. So what we did, we now wanted to turn on back to normal the brain of these addicted rats to cocaine and see whether they would stop self-administering cocaine. And we did it with the technology invented at Stanford University by a friend of mine, Tardysonov, that allows us with the fiber optic to turn on back to normal brain activity of these rats, and then see whether by rebalancing brain activity, these rats would stop self-administering cocaine. And what you see in this graph, these are the lever presses before turning on back to normal, so to say, the frontal cortex of rats, and these are the lever presses after we return on with this fiber optic the frontal cortex activity of these rats. As you can see, they almost immediately reduce very significantly cocaine self-administration. So we demonstrated with this nature study that even rats, when they are addicted to cocaine like people, have a reduction of activity in the frontal cortex, very important, but when we turn on the frontal cortex, now they don't want to take cocaine anymore. And based on this study, we started doing clinical trials to use transcranial magnetic stimulation in patients in the most complicated, desperate cases of cocaine addiction, and see whether by turning on again the frontal cortex of these people, we would see a reduction of cocaine self-administration. And these were patients that were addicted to cocaine or used cocaine for 16.8 years before TMS in the TMS arm versus 13 years in the control group. So big users, heavy cocaine users, almost 5 times per week. And when we did TMS for 4 weeks in these patients, 70% of them had urine drug test negative very quickly after this cocaine treatment. And the non-TMS arm, only 19% of these patients had urine drug test without TMS. Then we recycled the 10 patients from the non-TMS arm and offered them TMS. We offered it to all 13, 10 accepted, and the same story. Out of these 10 patients, 7 out of 10, 4 weeks of TMS, urine drug test negative. So they didn't use TMS anymore, just with 4 weeks of TMS use in 70% of cases. After the study, we kept on doing a lot of data collection, treating every patient with cocaine, alcohol addiction, pathological gambling, you name it. And we kept on treating anybody that really wanted to do TMS. So we analyzed later on the results of about these 1,000 patients. And after we did actually a longer treatment, the treatment was about 36 sessions over 10 weeks, because we learned that 4 weeks were not enough. And we increased actually our success rate from 70% above 80% and plus. And what we noticed after doing TMS for longer, in the TMS group, this light beige group, was that half of the patients relapsed once after 91 days, while in the non-TMS arm, the light blue group, half of them relapsed after 51 days. But the most important part is that even when they relapsed, you see the yellow line, on average, we follow these patients for 24 months. On average, they only relapsed once or less every month. So they went from 4, 5 times a week, and 45% of these patients were daily cocaine users, to less than 1 time every month. So a massive drop of cocaine use after TMS. And this study was actually the clinical trial that got TMS approved in Europe for addictions, including cocaine addiction. So we are very proud of this work. And what do patients say usually when they do TMS? And these are patients, some are young, some are older, male, female, highly educated and successful, or very normal people with normal jobs, but they all tend to say the same things. I don't think about it anymore. I don't want it anymore. I don't dream about it anymore. Why was I doing it? Like, I'm turning on the frontal cortex. Why was I doing it? Now seems stupid, like they regained their ability to make decisions. And I see other people drinking or snorting cocaine in front of me. This is very important. And it doesn't touch me anymore. It's like they become distant and able to disconnect from the cues that make them want to use cocaine or drink alcohol or gamble and so on. And some cocaine patients say, I don't remember the pleasure of it, which is very curious. And we also did, because we saw that just in the clinic, several patients that came for a cocaine addiction or alcohol spontaneously said, I didn't tell you, doctor, but I used to gamble a lot. And now I don't want to gamble anymore as a consequence of TMS. So we did a study on that, and there are additional studies also showing that, like in cocaine addiction, the frontal cortex activity is reduced, like with cocaine or alcohol, in gamblers. And this is why we think that, by stimulating again the frontal cortex, also gamblers do respond very well to TMS. This was our study in comorbid cocaine and gambler patients, and we basically observed a major decrease in the gambling symptom assessment scale and the cocaine craving scale at the same time, right? Because by turning on the frontal cortex, we rebalanced both of them in terms of cravings and decision making. And more studies followed up after our studies on proving and showing why that TMS also works in pathological gambling. We also have, and now I'm in the last part of the talk, a series of other recent indications for transcranial magnetic stimulation. For example, long COVID symptoms, brain fog is a great example. Low energy. We have seen it with many of our patients, but this study shows also that it does help also for long COVID symptoms. We have studies showing that eating disorders, that compulsivity to eat and not stop, that is also helped by TMS. This is an example of a study, a recent study. And there is evidence also that internet disorders, like internet gaming disorders, those video game obsession, we have treated quite a few young patients with that as well. And TMS, like alcohol, cocaine, gambling, does also help with internet addiction and video game addiction. This is something that we don't talk a lot about, but even suicidal ideations, there is this beautiful study that I'm showing you here by Noah Phillips and colleagues showing that 66% of the patients that did TMS for depression, they actually had a significant reduction of suicidal ideation. So very effective, very important treatment as well. We have studies, recent studies done on Alzheimer's patients. And these studies, actually, beautiful studies show that in the early stage Alzheimer's, it does help with memory by improving quality of life. And it also, very importantly, slows down progression of disease. It slows down the progression of many patients with early stage Alzheimer's, very important. And then we have the traditional trauma, anxiety in adolescents, as I mentioned initially, adults, older population. TMS does help in all of these populations. So we are ranging from depression to addictions to anxiety to PTSD to Alzheimer's and more. We have also quite a few patients in Italy that we are treating for certain types of Parkinson's disease, and we are seeing great results on that as well. Again, if you remember the effects of TMS, the increase in brain oxygenation, the anti-inflammatory effect, release of many good chemicals, and brain plasticity, you can understand why TMS, depends on where you stimulate, can actually help in many different conditions. And now, what are the main caveats of TMS? What are the main problems? Well, the problems are cost. Very few insurances make it easy to cover TMS, and usually only for depression. So cost is an issue. A TMS session can cost $200-300 per session. And people have to do, as I mentioned before, 20 to 36 sessions. So it's usually more than $10,000 to do several weeks of TMS, even if it's, in many cases, life-saving. And so it's a commitment. People have to show up initially every day for the first 4 weeks, except for the Alzheimer's, Parkinson's protocol, which are less times per week, but for more weeks. And TMS, this is very important, is 100% dependent on the clinic that does it. So in a sense, TMS is not invasive, but is like a surgery. It really matters who does TMS. Precision, knowledge, having thousands of patients of experience to do TMS is absolutely crucial to get the highest possible success rate, because It's all about precision. We have navigation systems, for example, that are fundamental to make precise stimulation in certain brain regions, but not everybody has navigation systems. And the navigation system is a second machine, independent of TMS. So there are many details that can make TMS very successful. As I mentioned, 80% success, 90% success, or 30, 40, 50% success only. So that is one of the main issues to look out for TMS. As for the side effects, they are very mild. Usually, in our experience, less than 10% of patients may have a headache once or twice. Usually, they may feel initially lightheaded, or very rarely they feel discomfort in the area of stimulation. It's like a AAA battery stimulating on your forehead, but those are usually the side effects. And so very easy, very light. So in this brief talk, I just wanted to show you how important research is, because we started from a basic science article and we ended up running clinical trials. And since then, since 2014, we have treated thousands of patients thanks to the science that demonstrated why to use TMS in addictions. And in conclusion, as I started, we need to work together. TMS is rapidly expanding, but is not a substitute to other forms of therapies like what Maria Elena does, or what many therapists do, or what physicians have to do. Medication management, correct diagnosis with our therapists. And TMS has been around since 1985, so for almost 40 years. And it has shown that in most cases has a higher success rate than medications. And also there are conditions like pathological gambling or many types of addictions where there's no medications anyway, so it's better than those in general. And in conclusion, because I want to leave time for questions, these are all the lab members and the people in the research team and in our clinics. Oh, Marielle, and I didn't update this slide. I'm sorry, I'm such a donkey. This is an old slide. I'm going to put your name here. And
no worries.
Sorry. This is another. And I want to thank NIDA, State of California, of course, and other sources of money that supported these early studies that led to use TMS for addictions. And I'm gonna, stop sharing the screen. And if you wanna ask me any questions.
I don't have any questions. Thank you so much for sharing all this information, so well explained and so relevant. And it has been a pleasure to have you with us.
My pleasure, Paulina.
Thank you.
So you have my email. If you have questions in the future, you can ask me anything.
Of course. And if you send us the presentation, we will send the presentation with all the people that wanted to hear your speech.
Absolutely. I will do it later today.
Okay, thank you so much.
You have a wonderful day.
Thank you.
Bye.
Bye.
Bye, Maria Elena.